Welcome to the Medical Collective, your go-to podcast where medicine meets real life. I'm Dr. Keisha Davis, a pathologist, personal trainer, and your host. I will be joined by a vibrant team of doctors who are not just healthcare professionals, but artists, fitness enthusiasts, and advocates for change. Each episode, we dive deep into the world of medicine, from untold stories of the healthcare industry to the latest in medical advancements. We're here to bring your insights, answer your burning questions, and explore the art and science of healing. So let's get started and step into the world of the Medical Collective. Welcome back to another episode of the Medical Collective. I am doing a solo episode. I'm your host, Dr. Keisha Davis, and I love doing this with you. This is near and dear to my heart as somebody that's not only a physician that diagnoses breast cancer, but as a patient. I, for over 10 years, have had to get mammograms, ultrasounds, even MRIs of the breast, and I've had multiple biopsies. So I can feel the angst, the anxiety around this subject, breast cancer, and just getting a mammogram. But I'm going to tell you that understanding it better will make it an easier process. So welcome in as we talk about what happens after a biopsy. So I want to start with something. When you hear the words, "we found something on your mammogram," a lot of people panic. Even when you go in with for that second read, you may panic. Your heart drops. You feel like, oh no, this is bad. And you don't know what a biopsy entails. You don't know how you're going to feel afterwards. But I'm going to walk through what happens when you get that biopsy or when you have to have more surgery after that, okay? This is one of the most common questions that I actually get. What happens when, I get this tissue taken out? What are you doing with that tissue? I'm going to go behind the scenes and explain to you what really happens in the laboratory. The doctor takes that biopsy, and I'm going to tell you what happens to that tissue, the whole process, and how it ends up in a report. Now, first of all, let's walk through this step by step. A biopsy actually doesn't mean a single thing, okay? There are many different ways that we can get tissue from you, a small amount of tissue. The traditional way sometimes, especially if you may have something that's fluid-filled, which is called a cyst, is that they would go in with a very, very, very tiny needle, smaller than the needle that takes blood, and they would gather fluid out. That fluid we would look at on a slide under the microscope, and that's called cytology or cytopathology, and we would render a screening diagnosis that it's negative or we see malignant cells. Mostly in cyst contents, you don't see much. That's one way. But most biopsies are what we call a core needle biopsy, where I think maybe taking a pen, they can range from the end of a pen in diameter to larger of tissue that's taken out with a core needle, or something that's called a vacuum-assisted biopsy, and we get a little bit much more tissue in those biopsies. They can be taken different ways. If you have an ultrasound of your breast because you have a lesion you actually feel, and I hope everybody's doing their self-breast exams, if you have an ultrasound-guided biopsy, that is getting some tissue out through that procedure, and that will come to the lab. If you have a CT-guided biopsy, because things were found maybe through calcifications, they also do the same process to get tissue out. And there's also an MRI-guided biopsy. So some type of radiology is guiding the radiologist on getting the tissue to make sure they're in the right place. They also will place a clip in there to know where they went. It's just a small marker that guides them if you have to get actually a lumpectomy or a mastectomy. I hope that makes sense, okay? Now, fine needle aspiration biopsy, just to review, fine needle aspiration biopsy. Quick little procedure for something that is fluid-filled. Solid lesions, that's when you go into the core biopsy of tissue. And because it's still small, pressure is placed. I remember laying there maybe for 10, 15 minutes while pressure is placed, right, to make sure you don't bleed. You take the rest of the day easy. That's an excuse for your significant other or your children to take care of you because you don't want it to bleed or get a hematoma in that area. But you just take it easy for that day. The next day, everything is pretty much normal. There's another type of biopsy that is not as common, but we call an excisional biopsy. It's when a lesion is seen, and instead of going in to do a needle, they're just going to go ahead and take the whole thing out. And at the time that it's taken out, we are also excising it and doing a biopsy because it's the first read. It's the first time we've ever looked at that under the microscope to give a diagnosis. So that's called an excisional biopsy. Okay? Now, once you get your biopsy, and I'll go into it a little more detail, once you get a biopsy, and if it's something that needs to be evaluated further or taken out, that's when you have a lumpectomy, which is not as big as a procedure as a mastectomy. So it's usually a lump of tissue, should I say. Some can be small depending on the amount of breast tissue you have or how big the lesion is. Some can be bigger amounts of tissue. And that's taken out with margins, meaning that the surgeon wants to make sure from us that we've gotten everything out. Now, the mastectomy is when the entire breast tissue is taken out with the skin that's on top of your breast and sometimes with or without the nipple, just depending on what the surgeon decides to do. I hope that was it. Now, when that biopsy is taken, you're wondering what happened to it. Now, Dr. Keisha, it takes forever. The doctor tells me a week, and I'm sitting here, right, tapping my fingers, wondering what it is. Well, let me tell you what happens. Now, if you are in a location where there's a lab directly there, things can happen and go to the lab within the same day or the next day. There are some places that are remote, right? If you're in a rural area, the pathology may not be where you had the procedure, and it has to travel there. So everything's put into a container, and it's put into a special solution. And the reason why is that breast tissue is important and delicate. It has to be fixed in something called formalin. Yes, that's that formula that can be cancerous, that can be toxic, and it's closed in a container. But for the tissue, it keeps the tissue intact so it doesn't break down. If the tissue breaks down, then me looking at it under the microscope, and then if it's cancer, me doing the special test, your prognostic markers, all of that can be hindered because it was not fixed. We have to note the time that it was put in formalin, and we have to note the amount of time it was formalin actually in our report. Yes, in our report. Now, once it gets to the lab, we have to do a check, right? Just like in surgery, they ask you, where's your band, your name? We have to make sure that the piece of paper called the requisition matches. If there's a barcode for some of the places that do it electronically, it's barcoded, everything matches. And then it's accessioned. That's accessioned by someone in the lab. The people in the lab, you may never see them, but they are amazing. They do the same work. Without them, I couldn't do my job. Now it goes to the PA. Some small labs, the pathologist actually does it, or the physicians or pathology assistant will look at the tissue. For a biopsy, they will say, okay, here's a small core of tissue. They will actually measure it. They'll put that all in a report, and then they'll put it in a cassette. And it literally, not the type of cassettes we had back in the days, if you are from the 80s or 90s, but it is a rectangular piece of material that closes, and it has little opening spaces so it can vent, but the formalin can go in there. And that's where the tissue continues to fix until it goes through a machine called a processor. The next day, it is processed. It is ready for the histotechs. Yeah, it's like an assembly line, you see? It goes to the histotech. The histotech now is receiving it, and it's in wax. Literally, think about it almost like a fossil. It's now in a paraffin wax that allows it to be cut into small, very thin sections, what we call micrometer-sized sections, and the tissue's in that wax. And when it's laid on the slide, you can't see anything. But then it goes and it gets stained. It goes through a stainer. Once it's stained, they make sure that everything still matches up, patient, name, everything. They label it and they assign it to a pathologist, and it comes to us. Biopsies are the number one priority. right? Because we're getting things that they're waiting for to find out the diagnosis to treat you. So we make sure within 24 to 48 hours, we're signing that out, unless it's something that's complex where we have to show other people, where we have to order more stains, that takes more time. But biopsies get the first process. Now, when we look at it under the microscope, if it's benign, we write as such. Some benign things that you may see and you may hear about is fibrocystic changes. Now, just fibrocystic changes in your breast are okay and benign. They don't increase your risk factor unless you have what is called hyperplasia or usual ductal hyperplasia. That slightly increases your risk for cancer, but we note that. We also note if we see atypical changes, which like atypical ductal hyperplasia or atypical lobular, those also increase your risk factor for cancer. And then if we actually see cancer. Now, there's many types, but for this conversation, I'll simplify it to the main types are ductal and lobular. The ductal cancer, or DCIS, is a cancer that hasn't broken the fence. That's how I describe it. It's in situ. It's contained in a sense, though it may break the fence later, which is why you need to get it out. And it can also lead to invasive ductal carcinoma. So once it's broken the fence, it's either invasive ductal or invasive lobular, among many other types too. Hello, listeners. We want to remind you that you can catch The Medical Collective on all your favorite podcast platforms. That includes Apple, Spotify, and YouTube. Be sure to hit that subscribe button so that you never miss an episode. We're also on Libsyn, and you can find us on all social media platforms as The Medical Collective. Do you have thoughts or questions? Please don't hesitate to reach out. We love hearing from you. Now let's get back to the conversation. When I get a cancer, I am going to look at three things. I'm going to look at your cells. And if you remember from biology, the middle of your cell has a nuclei. I'm going to look and see, and I grade the nuclei based on how well it looks. If it's very atypical, it gets a 3. If it's pretty good looking, it gets a 1. I also look and see your normal breast tissue is like little circles or acini, what we call glands. And if they have a lot of glands, you get a 1. That's good. If it doesn't look like normal breast tissue at all, it's just haphazard sheets, it gets a 3. And the third thing we look at is your mitotic rate. That is how fast is it dividing. Does everybody remember mitoses? That's how the cells divide. Well, cancer does not have any behavior, and it divides very fast. And the more atypical it is, more high grade, it divides more fast. So we count the mitoses literally per high power field. We add all that together to get a score, and you put it into 3 grades: well, moderate, or poorly differentiated, group 1, 2, and 3. We put that all in a report. We also make sure that a second pathologist at least, or what we call consensus conference, where if there's a group of pathologists, they'll all go together and show their cases. And they'll be like, okay, this, we agree with you. We'll make sure we note that in the report. We'll call your physician and tell them what we saw, and then we'll sign the case out. Now, once it's cancer, there's another part, and that's your prognostic markers. And the reason why is because we have shown through studies that some of the main ones, which is your estrogen receptor, ER, progesterone receptor, PR, and HER2/neu can guide treatment and also prognosis of your cancer. If you've ever heard of triple negative, that means that all 3 of those are negative, and that usually can portend a poorer prognosis. If you're ER or PR positive, you can get treatment to help with that, because that means your cancer is hormone sensitive. We do an additional thing that is very similar to the mitotic rate, which is our proliferation rate. So sometimes you'll get 4 markers done, and that'll come sometimes in an additional report to your physician. All that helps the oncologist and the surgeon and the whole cancer team decide the best treatment for you. How well does your tumor look? How big was it on radiology? Did you have lymph nodes that are concerning? All of those things help with guiding on what they're going to do next after the biopsy. Okay? So once we found out what kind of tumor it is, the question is, what do we do next? Okay, what do we do next? You've had the biopsy. Hopefully it took less than a week to get that back, the report back to you. You're speaking to your oncologist. They're giving you and guiding you on what they suggest. If it's small and you don't have a lot of high risk factors, they may suggest just a lumpectomy with radiation or with chemo. This all depends on your situation. There's not a cookie box cutter. And I also suggest you really talk to your oncologist about it and don't Google or ask a friend what they did, because every case, no two tumors or no two people are alike at all. They may recommend that you get a mastectomy as well. If you had multiple lesions, they may also recommend that you get a mastectomy. If you had calcifications, we are making sure that the calcifications were in the biopsy. If they didn't see them, they may say we might have to go back, or we still saw some other areas that we're concerned about. This is what we recommend. Okay, all of that. So let's say that you get the biopsy, and now they're recommending you get a lumpectomy or a mastectomy. Okay. Now, usually when that happens, or if the imaging, you didn't have a lymph node biopsy yet, you're going to have that during the surgery. Okay, and that is called a sentinel node. So if you remember, your body has lymph nodes all over. Sometimes when you're sick, right, or if you shave wrong, you'll feel those little lumps. So you don't know. Sometimes it's just reactive or due to an infection. But when it has to do with cancer, they're going to image it, and they're going to look for the first nodes of concern, or the first nodes that breast tissue would go to if it was draining. And those are called the sentinel nodes. The sentinel, or the big event, you've heard of the word sentinel, those are the sentinel nodes. So when you're sleeping, having that good sleep during surgery, they are sending those sentinel nodes to the pathologist, and we're looking at them. We are taking them during surgery, and that is called an intraoperative report, or what we call a frozen section. If we need to, we'll freeze the tissue. Some pathologists will just take the lymph nodes. We will do what is called serially section them, and then we'll dab them on a slide, and we'll look at what is called the touch prep. Sometimes that works. If we're not sure, we'll go directly to the frozen section, which we freeze the tissue in real time, not overnight like the biopsy does. And we will be able to tell the surgeon if the lymph node's positive. If it's negative, they're not going to do anything else with the lymph nodes. They're going to stop there, because more than likely, if the sentinel nodes are negative, you don't need what is called an axillary dissection. If they're positive, they're going to continue on, because you want to be able to be staged. And the stage of your cancer includes how many lymph nodes are involved. Okay, that's why you may need more lymph nodes done. Now back to the breast. Now, if you have a lumpectomy, you're going to have a smaller piece of tissue taken out, okay? We have to know the margins, and the margins are the important part of knowing if there's tumor left in your body. When they cut out the tissue, it looks like a football lump, right? And what's left in your body is your cavity in that area. Now, we have to know and make sure that everything that was taken out, the tumor's contained in it. So we will ink a whole bunch of different colors. We do superior, anterior, posterior. We make sure we get every margin. We will ink it. We will fix it with vinegar. And that's the part that smells good in the lab, is the vinegar. And we will section the breast tissue, the lumpectomy. This is also done in real time. The surgeon comes down most of the time, some of them do, and they want to see it. So we're giving them an intraoperative consultation and telling them, oh, here's your clip. Because remember the clip I told you about? Here's the clip. This is the area of concern where we diagnosed cancer. And we see the atypical white mass that looks like tumor. And all of your margins are free. Now, if we see the clip, or we see something that looks firm, and we see it, oh, it's really close to the deep margin, the surgeon will go back while you're in surgery and will take out additional margin, right, to make sure that we get all the cancer in the tissue. Even with a mastectomy. With a mastectomy, you're getting most of it, right? But it's at the lumpectomy where they really have to be sure that they don't get anything. Now, they continue on with surgery. We let it fix so it's nice and firm. The formalin fixes it so it's easier to cut. And then the PA will, or the pathologist will measure the size of the tumor, talk about how far it is from every margin, and we'll cut sections. Now, when you're doing a lumpectomy, you're not going to, like a biopsy, everything goes through. You're going to do as much as you can. You're going to submit all of the tumor. And if it's really, really big, all the margins at least, but not all of the fatty tissue. That all goes into cassettes, and it goes through the same processor, and it comes out the next day. If it's a mastectomy, similar way, we will cut it in sections and leave the skin intact. We'll look at the nipple. We'll take sections of the nipple because sometimes tumor can involve the nipple, and that's called Paget's disease of the nipple. It also changes the stage. Sometimes people have what's called inflammatory breast cancer. It's not a special type of cancer, but it's when either lobular, ductal carcinoma, or another type of cancer is directly in the skin. So it's going up into the skin, so you can see it sometimes actually in the spaces of the skin, what we call the lymphatics, and that's why it presents or looks like a rash to you, because it's involving the whole skin. So that's important to note in our report too. Okay, so now it goes to the pathologist. These will take longer. So you've had your biopsy. Now, whether it's the excisional biopsy, the lumpectomy, or the mastectomy, because this is a bigger specimen, we spend time on it. I try not to personally sign them out in one day. I want to make sure I'm getting everything right. We measured it by eye, but now we measure it by microscope, which is even more accurate. It's important because the staging, the pathological staging, depends on the size of the tumor. So if we have something that's 1 centimeter or 3.5 or 8 centimeters, it's very important that we get that. It's also important we tell microscopically how far the tumor is from all your margins, right? So the surgeon is clear on that. And once we do all that, we also talk about the grade as well. If we see it in what is called your lymphatics, right? It means that it could be in a vascular or lymphatic space. That's important. If we see it next to a nerve, which you may wonder sometimes if you have breast pain with a cancer, it's because it could be involving the nerves. All of that is put into the report. And we do something called a CAP cancer checklist. And that is important for all pathologists to do the CAP cancer checklist, which will put everything in a succinct format. And it guides the oncologist and the surgeon and the radiation physician, if there is one, on what to do based on that. If you're at a cancer center, once all of this is signed out, once I talk to the doctor, sometimes cases are presented at tumor board. The tumor board consists of the pathologist, the oncologist, the breast surgeon, the radiologist, and we go over everything. We go over our part, the radiologist talks about the imaging, and then everyone gives a suggestion on guiding the treatment for you as the patient. So rest assured that a lot is happening behind the scenes to get to the final diagnosis and treatment for you. Sometimes I've seen cancers that aren't very straightforward, and so what do you have to do? In those situations, that's when we may have to do additional immunostains. I've had cases where one was a sarcoma of the breast after radiation, and we weren't quite sure. We had to send it to multiple specialists, and they even weren't quite sure to render an accurate diagnosis. Yeah, so it can take a lot, but I do want you to know that it's all done for the best interest of you. And this also guides what is called precision medicine, based on the biomarkers, based on your clinical scenario, even what's going on in your personal home life. They'll recommend when and how you should be treated. And you do ultimately have the say on what you want, but it's important you also take into account what the physician's recommending. But this is happening all behind the scenes. We are the behind the scenes doctors. We are medical doctors. We went to medical school. We went to 4, 5, 6+ years of residency and fellowship to do this. And we are the doctor's doctor having this conversation. So Breast Cancer Awareness Month Breast cancer diagnosis is personal to me as a loved one who's had family members that have had it, as someone that is going through is high risk because I have dense breast tissue. And I'm someone that also sometimes worries about my own risk factor. I understand how important it is. And I also know whether you're a man or a woman, that it affects all of us personally. So I take this personal. I take this in a very sensitive way, and I really hope that this informs somebody. You're welcome to share this episode. You're welcome to also go back to the episode on Know Your Breast Density, which I think is very important from last year during Breast Cancer Awareness Month, as breast radiologist Dr. Islamiat and Dr. Sharon Smith, who's an obstetrician and gynecologist, we all talked about the roles we play in helping you help yourself. So until next time, everybody, have a great time, be empowered, and take care of your health. Thank you for tuning in to The Medical Collective. We hope today's episode has left you with valuable insights and a new perspective on healthcare. Don't forget, follow us on social media for more updates and behind-the-scenes content. I'm Dr. Keisha Davis, and it's been a pleasure to share this time with you. Stay healthy, stay informed, and we'll see you in the next episode, where medicine continues to meet real life. Please note that the content provided in the Medical Collective podcast, including text, graphics, images, and other material, is for informational purposes only. The content is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding a medical condition. The views and opinions expressed on this podcast are solely those of the individual authors and guests and do not represent those of the Medical Collective, its staff, and any affiliated entities. The appearance of content on the podcast does not imply an endorsement. Neither the host, Dr. Keisha Davis, the co-host, or any guest of the podcast bear responsibility for the accuracy of the content provided or the use of information received through the podcast. Reliance on any information provided by the Medical Collective podcast, its employees, writers, or guests is solely at your own risk.